are so happy to have you here. I'm welcoming you all for with the Emirates Nursing Association and the Compass Health Consultancy. Um, After Dr. Johansson presentation about the timeout, he already spoke about the timeout from operational perspective, preparation, understanding, and how you are actually dealing with the situation. And what is he highlighted a lot about the documentation and the knowledge and verbalizing and understanding and all of that. So thank you so much, Doctor, for your for your thoughts and for your presentation. And for me, I want to speak about timeout as a critical indicator for safety and better patient outcome in the operation room from a quality point of view, quality perspective. And we want to focus on the patient verification and the team communication inside the theater itself, and the wrong side prevention, how we are able to identify it, and how we do measuring for the OR reliability through electronic system, through verification, through ideal protocols that we have using dashboards. And the message from that is like cognitive pulse, shared situational awareness, and stop the line safety culture. So I welcome you all in this presentation, and thank you so much for attending this webinar. So before we start to do or to speak about that, I want you to consider this as actually it's something really, really important as a part from the international patient safety goals, and it can lead to life-threatening situations. And it can really, really make a big difference in people's life. So startingly, if I want to say about the core elements of the high quality timeout. When I say what is the core elements, I need to understand first what is the high quality timeout that I want to achieve. For example, if I want to start doing checking the quality timeout that I have in the OR, I need to make sure that I have, first of all, 2 identifiers for the patient. I have to make sure that I am doing a match for the wristband. I have to make sure that I have proper charting for the patient, proper consent, proper identification. I have to make sure that the full procedure with the code that I have for the patient is matching what I have in my system or my papers. I need to make sure that the patient should be laterally, should be supine, should be semivowler, should be which side, what is the visible mark that has the patient. Plus, we need to go a little bit about a clinical risk confirmation that it's actually highlighted more about what is the allergy the history that the patient have, what is his present illness, if he has any airway concern, if he has a risk of a separation, if he's vulnerable, if he's above 65, if he did multiple surgeries before, and when was the last surgery he did. And one more thing that many people that are not really concerned when we speak about the preparation of timeout and the timeout process itself, that the antibiotic prophylaxis and the anticoagulation that we are giving to the patient, when the process of antibiotic was started, when the antibiotic will finish, how I will make sure that really it's actually given like 30 minutes or 1 hour or in the beginning of the before the incision of the patient or the skin breakdown. And the estimated or the accepted blood loss that we'll have from the surgery, especially for the surgeries like, let's say, the vascular surgeries, So for me, I need to put in my consideration all these aspects from a quality point of view. My equipment, my anesthesia machine is working, my monitor is working, I have a backup machine, I have ready equipment for the airway, I have, I have a circulatory nurse, scrub nurse, I have backup nurse there, I have a surgeon assistant for the surgeon, um, um, I have like a good access. So all these core elements is concerning about what or how I can make a proper time out inside the theater. So best practice that we have one leader, one script, one shared understanding. Now, for the people who are actually working in the OR and they are actually interested in the OR, they know that maybe the timeout process will be done loudly. There will be a verbal communication between the team and the surgeon and the anesthesia through a specific dashboard or through a specific form inside the OR and proper checking for that checklist. So that will give us an idea about where we are standing inside the theater. So why this is actually very, very, very important, because it's covering a core element of high quality of timeout. So now let's go to think more abroad inside the quality of the timeout as a clinical quality indicator. How quality measures the reliability of pauses before the incision. Yani when I start to speak about the procedure or the timeout, I make a pause before the incision, everybody is silent, everybody is listening to me to what I say. So clinical indicator in that particular point defined as a measurable process showing whenever the full timeout occurred correctly, loudly, and with the whole team before incision. Now, I just want to highlight a little bit about, we will talk about it in more details in a few slides, but I wanted to talk about the using of system, the using of electronic system in doing that, or using of a specific dashboard can give me a specific information attached with the time. So it will be much more reliable and much more objective. So once I do the timeout inside the theater, I have to click or check on that we did it exactly, for example, at 6:28 p.m. So at that moment of time, that capture data that I have will affect, first of all, my incision time, will affect my legal aspect regarding the timeout, and it will focus not only in the whether the form was signed by the patient and procedure, but it will give me an idea where I am actually confirming and what kind of way I am confirming. So how I will do that? By firstly checking the data source, the quality view, and the target, and the numerator and the denominator, and the surgeon himself need to be accepted this or approval on that before doing the procedure. Now, let's go more about the quality perspective by how to measure whenever timeout is truly working or not. Remember when we mentioned at the beginning that we are actually using dashboards, we're using system, we're using verification. Now, once you admitted the patient on the system inside the OR and you start the procedure, the system will give you automatically that the timeout need to be done now. And he will stop you from doing any documentation at that moment of time unless you do the timeout properly. So once the timeout is done and it's confirmed by the surgeon and confirmed by the circulatory and the OR team, then after that, we want to see that we are actually doing truly timeout or not. First of all, process metrics that I need to first pass compliance with full verbal timeout. Means I'm standing inside the OR, I'm giving a full loud verification for the patient. Patient participation in the site marking visibility, like I'm using a permanent marker. It needs to be site, it's right leg, left leg, right lower quadrant, left lower quadrant, whatever. And second thing, that the antibiotic timing, as we mentioned in the introduction, antibiotic timing is very important, and it should be given 30 minutes to 1 hour before the surgery or before the incision. Outcome metrics, wrong site or wrong procedure, near miss need to be verified. And the culture metrics, speaking up behavior across all disciplinary. If you suspected that you have a problem, if you suspected that you are unable to do this procedure for this reason, speak up before the incision time. And audit method, we have, of course, direct observation. We can use, let's say, in case that the system is available, that I'm not able to do any verification at that moment of time. So measure the pose itself, not just the paperwork after it. Right. Okay. Now, if we use like a system, and the system is reflecting for us a reliable data, as we mentioned in the introduction, how actually it will look like if I have a proper dashboard and electronic system for the timeout monitoring. Remember, we are actually speaking about the quality perspective, not only the operational perspective. So if I have, in this example, if I can see in this example in front of you, now the dashboard example is giving you that the electronic system convert timeout performance, okay, into real-time quality data. Now, the leadership can see completion rate, on-time performance, read back documentation, and open discrepancies. If you can see this slide, like let's say, for example, I'm sitting in my office as a chief nursing officer, and I want to check exactly what I have, was the timeout exactly today, when was the procedure was done, when it was finished. I just go to my electronic dashboard and I start to check all this. Now, that's the responsibility of the nursing leadership or the nursing admin or the OR admin to make sure that this process is actually done perfectly to reach up to 100% compliance. Now, the workflow should be prompt the timeout before incision. And I'm highlighting that before incision because if you did it after incision, that we are not having any reliable data. And also the dashboard updated automatically because it's connected with time that you press or that you enter the data at that moment. The organization can monitor trend, coach unit hits, and react quickly instead of waiting for delayed reports. Like if I want to see that I have, let's say, 100% compliance at that moment of time, and I have a compliance of the antibiotic, let's say 88%. The next month it was 90%. The consent was signed exactly 94%. 95% I have, let's say, the patient arrival within 15 minutes to the OR. So all these aspects, I will collect it and I will work for it in order to make sure that I am 100% compliance. Right, okay. Now, because I have the availability of electronic system, HIS or EPIC system, or whatever is actually controlled from my side, electronic tracking for legal protection and patient safety. Now, in USA, it's very, very important, and it's very, very aspectly very important that your documentation is actually protecting you from having any legal issues. Now, let's say that you admitted a patient to the OR and you didn't do a proper timeout. What is the perspective? What is the legal perspective for the physician himself, for the OR team, for the hospital, the hospital repetition, and what is the legal aspect from that part? So legal and regulatory values is time stamped evidence of what was confirmed and when. That's how the system will help me identify who participated in the timeout, who's the person signed electronically, create an audit trail for investigation and review. Now, from patient perspective, prevent any missed checklist, prevent any missed mistakes. Any mismatch will be tagged immediately. And we are actually supports rapid escalation when the team find there was a discrepancy. Now, from quality governance values, especially for the hospitals that they have shared governance program, turn every case into measurable data. These data will be reflected in your dashboard. It can be used later on for improvement purposes, okay? It can increase the highest care given to the patient, increase the patient satisfaction, increase the patient or better patient experience, and maintain or make sure that I have a patient-centered care as part from the nursing department. Help leaders proven reliability during accreditation and review. If you have accreditation for CBAHI, GCIA, Magnet, whatever you have, it's like confirmation for your work. Now, a digital timeout creates a very traceability, accountability, and safer escalation. Electronic trial supports safety and legal responsibility, as we mentioned. In order to make it much more easier and much more understanding, let's take this case study. The case study is like timeout prevented a wrong side operation. Now, before the timeout, I have a patient is booked for a left knee procedure, but the schedule entry and the room board shows that it's right knee. The patient is prepped and draped. The surgical team is ready to do the procedure quickly because they are in a hurry because they have a lot of patients and they have a full schedule. During the timeout, the nurse reads the consent, site mark, and imagining aloud. The mismatch is noticed immediately and the team stops the line. Now, during and after the timeout, the surgeon anesthesia team and the nurse recheck the consent and marking. The order is corrected before incision. The correct side is confirmed verbally, documented electronically, and the case is processed safely. A wrong site operation, reoperation, and avoidable legal exposure are prevented. So here is that what we have before and what we have during and what we have after. Why it's actually matter? Because timeout is a high value clinical barrier. It catches an error when it can still be corrected, protecting the patient, the team, and the organization. And as the doctor mentioned, he giving you like a huge number of data of mismatch that's happening in yearly based in USA, which is very, very, very big numbers that we are actually trying to decrease year after year. Now, if we want to, at the end of this lecture, what we want to take as a key take ways. First of all, treat the timeout as a patient safety intervention, not a routine task. And you need to do it every single time as something not routinely. It's an interactive intervention part from the procedure that you want to do, part from your checklist, part from your international patient safety goals that we are actually applying everywhere, and specifically the OR. Standardization improve reliability and reduce variation in practice. And once I have a standard procedure, that's mean I will make sure always that I'm doing the same workflow and pathway. And we don't want to forget effective communication in the foundation of safe surgical site. When I have a proper, loud communication inside the theater, okay, I'm highlighting and I'm making sure that everybody's understanding. I'm speaking English, I'm speaking one language, and everybody can confirm my timeout language. Every team member shares a responsibility of speaking up, as we mentioned, for verifying any critical information. And also, as a nursing leadership or as a leadership generally, regular audits and feedback helps sustain long-term improvement. And while I'm doing that every single day, I'm actually making a strong safety culture for my staff, for my patients, for my surgeon, and for my organization. So a strong safety culture transforms a brief pause into wonderful harm prevention strategy. And success of timeout is actually measured by meaningful engagement, not by the speed. So even if I have a long day, a long procedure, I have a lot of procedures daily, I need to make sure that I'm doing this every single time without any speeding up. Every pause before the procedure is an opportunity to prevent an error. Just put it in your mind and make sure always pause, always pause, always pause, always verify, always communicate, and always protect. Now, a specific timeout prevent harm today. Like if you do the timeout today, you are preventing the harm of tomorrow. You are strengthening the culture of patient safety in your hospital. Thank you so much for listening and for joining our webinar today. Last message, always pause, always verify, always communicate, always protect. Thank you so much. Thank you.